I request Dr. Neena Jayashankar, pediatrician. She is a senior pediatrician practice here. To introduce the next speaker.
Good evening. It's been an afternoon of all youngsters, one after the other, who have been talking about fever and common illnesses. Last but not least, Dr. Thiyagesa Deva Ganapathy. It's my pleasure to introduce him. He is a doctor who had graduated from Sri Venkateshwara Medical College and Research Institute, Pondicherry. Did his MD in respiratory medicine from Mahatma Gandhi Medical College and Research Institute, Pondicherry, and also has had a fellowship in intervention pulmonology from Yashoda Hospital, Secunderabad. A youngster with a lot of credit to his in the field of respiratory medicine, and with expertise in bronchoscopic procedures and therapeutic procedures, and with quite a few presentations to his in his career. He will now talk about the common respiratory infections and their management. Thank you.
He is also younger, madam. Younger, still younger.
Still younger, yeah. Got a doctor.
Thiyagesa is still younger.
Ah, yes, very young. He's only 30 years. Yeah. Nice to see a lot of young kids. Yeah.
Good evening, everyone. And I'd like to thank IMA Chennai Metro branch to give me this opportunity to present this topic here. And my topic for discussion is approach to common respiratory infections. We will cover the spectrum of respiratory infection and a little bit of pathophysiology and classification of respiratory infections, and we mainly focus on approach to respiratory infections. Introduction. A respiratory infection can be classified as upper respiratory tract and lower respiratory tract infection based on the location of the pathogen. And pneumonia is the sixth most common cause of death in the world, and it's the second biggest cause of disability-adjusted life years in the world, and it's most common infectious cause of death. And pneumonia is the most common cause of IV antibiotic use in hospitals. Like upper respiratory tract infections is the illness caused by an acute infection which involves the upper respiratory tract, like nose, sinuses, pharynx, and larynx, and it ranges from pharyngitis, laryngitis, sinusitis, otitis media, and common cold. This is the spectrum of respiratory tract infection. The upper respiratory tract and lower respiratory tract is divided by at the level of larynx. Any infection which is at and above the level of larynx is called as upper respiratory tract infection, and anything below the level of larynx, like involving the trachea, bronchi, parenchyma, and pleura, is called as lower respiratory tract infection. And the spectrum ranges from rhinitis, tonsillitis, sinusitis, otitis media, pharyngitis, epiglottitis, and laryngitis in upper respiratory tract infection. And in lower respiratory infection, it ranges from tracheitis, bronchitis, bronchiolitis, pneumonia, and pleurisy. The common etiology of upper respiratory tract infection is rhinovirus, which is followed by influenza virus, and then it is followed by adenovirus. Its upper respiratory infections are mostly of viral etiology. And the brief pathophysiology of upper respiratory tract infection. When a bacteria, viruses which enters into our body, it will be acted upon by our post-immune defense mechanisms. And the ciliary hair lining, which is there in the nasal cavity, will filter and it will trap the pathogens. And the trapped pathogens will be coated by mucosa, and this will be then shifted to the posterior nose to the pharynx. When it impinges in the back of the throat, it will be then transported to the level of pharynx, and the inflammatory response will set in on it, like swelling, erythema, and increasing of mucus secretion and fever. So, the common defense mechanism of the respiratory system or mucociliary escalator mechanism, which is more common in the upper airway, and the alveolar macrophages, which is there in the lung parenchyma, and the muscles of the chest wall and diaphragm, that is also very important in producing the cough reflex, which plays a major role in the defense mechanism. When a viral pathogen enters into our human body, it will mainly affect the mucociliary escalator mechanisms. When the mucociliary escalator mechanism is being affected by this viral pathogen, there is a high chance that there will be a superlatent bacterial infection can easily enter into our host system. And in the airways, when there is an endobronchial obstruction or there is any anatomical malformations in the airway, there can be mucosal stasis can happen in the airway, which will act as an idus for growth of the organisms. And when a patient is undergoing any cardiac surgery or upper abdominal surgery, and when he is going for any trauma, there is a high chance that his cough reflex will be affected by the involvement of the diaphragmatic muscles and upper abdominal muscles, which will also leads to bacterial infections and pneumonia. So, in upper respiratory infection, the more common infection is acute rhinosinusitis. It is inflammation of the nasal cavity and sinuses, and it will be for the symptom duration will be less than 4 weeks. And the symptoms which is suggesting the bacterial cause of acute rhinosinusitis are prolonged symptom for more than 10 days, and unilateral maxillary sinus tenderness, and unilateral full and nasal discharge, and this entity called as double sickening. Double sickening is when a patient first harbors a viral infection, he will be having a first phase of symptom, which will then settle with the settling of viral prodrome. But as the mucociliary defense mechanism is getting affected, then he will go for a second phase of sickening by the bacterial infection or superadult infection. That is what we call as this double sickening. And the symptoms of acute pharyngitis or like in case of bacterial acute pharyngitis, you will be having a swollen uvula, white spots present over the tonsils, and red and swollen congested pharyngeal mucosa. And grey furry tongue will be more common in case of bacterial pharyngitis. In viral pharyngitis, the more common thing will be congested and swollen tonsils and the congested pharyngeal wall. And the symptoms will be sudden onset high fever, and it will be always associated with enlarged lymph nodes in the cervical. And the treatment will be commonly amoxicillin 1000 mg OD for 10 days in case of acute sinusitis. Diagnosis is commonly based of URTA is based on symptoms. Patient will be having symptoms like cough, sore throat, fever, and these upper respiratory infection of viral etiology will be commonly associated with generalized myalgia, tiredness, and physical examination. I'll tell the next thing. And laboratory tests by taking bacterial cultures with nasal swab and throat swab for diagnosing viral etiology. And evaluation of allergy and asthma is very important in case of upper respiratory infection, because the symptomatology of this post-nasal drip and upper respiratory tract symptoms will be more common with patients having allergic component also. And we have to assess for enlarged lymph nodes and sore throat. Physical examination of upper respiratory tract shows swollen and redness inside of nasal cavity and redness of the throat, enlargement of tonsils and white secretions on tonsils, and enlarged lymph nodes around the head and neck, redness of eyes, facial tenderness, and halitosis. It can present with hoarseness of voice and fever. So non-pharmacological management of upper respiratory infection is it's mainly hydration. So this hydration will help to decrease the viscosity of respiratory secretion, and use of vaporization will also promote thinning and loosening of the respiratory secretions. Pharmacological management is by giving NSAIDs, antihistaminics, antitussives, and the steroids and decongestant in case of acute tonsillitis. It will reduce the inflammation. And when a patient is having a presentation like stridor because of this acute tonsillitis, then they will have good benefit over the steroids. And antibiotics which we commonly use are ciprofloxacin, 500 mg BD, and oxyclar is 625 mg BD.
You are not using tetracycline.
Now it's not used in tetracycline, but all the guidelines they have been mentioning is tetracycline.
Approval is not used.
Yes, sir.
We are using amoxicillin for the
Tetracycline.
Tetra is out of
Now it is not being used.
Cipro is better to avoid this particular.
Why steroids?
It is mainly indicated in acute tonsillitis when there is enlarged tonsil which is causing compression of the airway. The steroids will help in resolving that inflammation. Symptomatically, it is just for symptomatic
I
better.
don't give good for drugs, but it's with the amoxicillin lolly itself is subsiding.
Not with, when a patient is having a stridor and respiratory distress,
Stridor?
those cases will be requiring steroids and decongestants mainly. Lower respiratory tract infection. Pneumonia is an inflammation of the lung parenchyma. It's mainly alveoli rather than bronchi of infective origin. There are many studies have been published on how to manage community-acquired pneumonias, and there are many societies like Infectious Disease Society of America, ATS, ERS, and British Thoracic Society, which they have been giving many guidelines for us to manage how to manage a community-acquired pneumonia. And ICS NCCP is an Indian Chest Society and National College of Chest Physicians, and they have given a guidelines based on our Indian epidemiological data. In this presentation, I will be mainly dealing with this ICS NCCP guidelines, like how to symptomatically identify a patient and how to diagnose the patient and what is a clinical approach for a case of pneumonia. So, the pneumonia is classified as viral, bacterial, and fungal based on the etiological thing, and lobar bronchopneumonia and interstitial pneumonia based on the morphological pattern, and community-acquired pneumonia, hospital-acquired pneumonia, and ventilator-acquired pneumonia based on the clinical syndromes. Lobar pneumonia is an acute bacterial infection which is mainly act on a part of a lobe or even two lobes or one or both lungs. Lobar pneumonia will be having very localized lesion like this, and we can see it involves only the lower lobe or a particular segment here. And in bronchopneumonia, the infection usually involves the terminal bronchioles and also the adjacent alveoli around the terminal bronchiole, which will be giving patchy consolidation like appearances, like we mentioned here. This is a radial cell picture of a bronchopneumonia. So this is the definition mentioned in British Thoracic Society guidelines. So when a patient comes to our OPD, when to call a patient as a case of community-acquired pneumonia. So in the absence of a chest radiograph, just a patient is coming to our OPD, the patient should have symptoms of acute lower respiratory tract illnesses like cough with or without expectoration, shortness of breath, pleuritic chest pain for less than 1 day. And at least one system features like temperature which is more than 37 degrees Celsius, chills, rigors or severe malaise. And along with this, patient should have a focal chest sign on examination like bronchial breath sounds or crackles with no other explanation for this illness. So when a patient presents with the chest radiograph, along with the clinical symptoms, the radiological pattern of pneumonia or patient should have a lobar or a patchy consolidation, loss of normal diaphragmatic or cardiac or mediastinal sellout, interstitial infiltrate, or bilateral perihellar opacities with no other obvious cause. This loss of normal diaphragmatic cardiac or mediastinal sellout is whenever there is a patchy opacity in the X-ray that will be overlapping over the cardiac shadow or the diaphragmatic shadow or mediastinal structures which will be obscuring the borders of the structure. That's what we call it as loss of sellout. So there are no large studies from India for the incidence of community-acquired pneumonia, but mortality-wise, the total number of deaths due to lower respiratory tract infection was 35.1 for 1 million population. And total infectious and parasitic disease death rate was around 194.9 for 1 million population. That's around 20% mortality is due to of infectious disease is caused by lower respiratory tract infection. So what's the etiology of community-acquired pneumonia? The microbiological diagnosis could be made only in 40 to 70% of cases. And Streptococcus pneumonia is the most common etiological agent, but the proportion is different. The viruses are responsible for community-acquired pneumonia in 10 to 36% of the cases. So the widespread antibiotic use is probably responsible for decreasing culture rates. So the most common etiological agents of community-acquired pneumonia in outpatient setting is Streptococcus pneumonia, Mycoplasma, H. influenza, Chlamydia. And in inpatient and non-ICU setup, it is Streptococcus, Mycoplasma, Chlamydia, and H. influenza. Associated along with that, aspiration and respiratory viruses are also more common in the inpatient setting. In the inpatient setting of a patient in ICU, Streptococcus pneumoniae, Staphylococcus, Legionella, and gram-negative bacilli are more common pathogen isolated for community-acquired pneumonias. So there are certain epidemiological conditions and certain risk factors which also have a particular species of organism responsible for community-acquired pneumonia, and I'll just mention a few of it. When a patient is a chronic alcoholic, the common etiological agent will always be Streptococcus pneumonia, oral anaerobes, Klebsiella pneumonia, and Mycobacterium tuberculosis. In a case of COPD and smoking, it will be Haemophilus influenza and Pseudomonas are more common than Streptococcus pneumonia, and Legionella species, and followed by the Chlamydia. In a case of aspiration, the pathogenic organism will always be gram-negative pathogens or oral anaerobes. In lung abscess, it will be MRSA, oral anaerobes, or endemic fungal pneumonia, or atypical Mycobacterium tuberculosis. And These are specific bacteria related to specific exposures. Like for example, for bird wrappings, it's histoplasma. For rabbits, it will be Francisella tularensis. And in HIV, the most common infection will be Streptococcus pneumonia. And the list goes on. With the common IV drug abuse, patients will have anaerobes as a common causative organisms. The clinical feature which is suggesting MRSA pathogen in a community-acquired pneumonia or cavitatory infiltrates or necrosis, or rapidly increasing pleural effusion, gross hemoptysis, or concurrent influenza, neutropenia, erythematous rash, skin pustules, and younger previously healthy patients and severe pneumonia during summer months. These are the common signs which we look for a MRSA pathogen in the case of community-acquired pneumonia. And we'll go for a diagnostic part now. The common symptoms of community-acquired pneumonia are fever, cough, sputum production, dyspnea, and pleuritic chest pain, and physical examination like focal areas of bronchial breathing and crackles. And elderly patients will exhibit very less of these signs. We can't expect all the signs to be there in elderly group of people. And based on the chest X-ray, the community-acquired pneumonia can be diagnosed by presence of increasing lung opacification and Silhouette sign, an area of increased opacity bounded by a well-defined interface of aerated lung. That is like we call it as bulging fissure sign, which is more common in Klebsiella pneumonia. And if only APV of chest X-ray is available, we have to look for increased attenuation of the cardiac shadow. It shows that retrocardiac infiltrates can be present. And for a radiographic widespread airspace disease, more asymmetric or multifocal distribution of opacification. At least any one of the signs is there, then we can call it as a case of community-acquired pneumonia. And it's very important that the resolution of chest radiograph will always be lagging behind the clinical cure during the follow-up. Up to 50% of patients may not show complete radiograph resolution at 4 weeks of time. However, when there is a lack of partial radiograph resolution we seen at 6 weeks of time, even in asymptomatic patient, we should require consideration of alternative causes like endobronchial obstruction or non-infectious causes like vasculitis, organizing pneumonia, and other causes. And is there a role for CT in a case of community-acquired pneumonia? Routinely, there is no role for a CT thorax because the community-acquired pneumonia can be diagnosed by clinical and X-ray finding. But CT is needed when there is a non-resolving pneumonia, or we have to assess for the complications of community-acquired pneumonia, like when a patient is having a gross hemoptysis or is having the features of sepsis and all those things. To assess the status, we can do CT, but routinely it is not indicated. And microbiological investigation, blood cultures should be obtained in all hospitalized patients, and it is not required in patients where we are treating as an outpatient. And sputum, gram stain, and culture should be obtained in all hospitalized patients for community-acquired pneumonia. The very important point is the quality of the sputum, what a patient is giving to us. So that can be assessed by this gram stain results. Any quality sputum should have less than 25 epithelial cells, and it should be more than 10 WBC cells should be there in the sputum. And the sputum for AFB should be obtained as per RNTCP guidelines. As we all know, we are a TB endemic area. We should always look for tuberculosis whenever there is an opacity in a chest X-ray. And pneumococcal antigen testing, it is not routinely required. Pneumococcal PCR is not routinely required in case of community-acquired pneumonia. And in a severe community-acquired pneumonia, Legionella urine antigen testing can be done. And routinely atypical pathogen analysis is not recommended unless there is a non-resolving pneumonia. We can go for assessment of mycoplasma chlamydia and other organisms. So general investigation, what we require in a case of community-acquired pneumonia. For patient in an outpatient setting, basically chest X-ray should be sufficient, and pulse oximetry should be done in all the patients. And based on that, when a patient is having oxygen saturation of less than 90%, ABG is always indicated. And indicated in a patient who is having chronic lung diseases. Blood glucose, urea, electrolyte should be obtained in all hospitalized patients with community-acquired pneumonia. And full blood count and LFT will also be helpful in managing the patient with community-acquired pneumonia. This procalcitonin and CRP are routinely not measured in an outpatient setting. And it is not used for diagnosis of community-acquired pneumonia. It's only used for escalating and de-escalating the antibiotics and monitoring the prognostic factor. And the clinical indication for more extensive diagnostic testing. In a patient, if a patient is there in intensive care admission, we need to do blood culture, sputum culture, Legionella antigens, pneumococcal, and others like ET tube aspirate for culture or bronchoscopic bowel washings can be done when a patient is intubated. And failure of outpatient antibiotic, if a patient is having failure of outpatient antibiotic therapy, we have to go for sputum cultures and assessment of Legionella pneumococcal antigen. And in a cavitary infiltrate, we have to look for blood cultures, sputum cultures. Along with that, we have to look for fungal and tubercle radiology. And in the case of leukopenia, blood culture is very important, followed by pneumococcal antigen. And in active alcohol abuse, we have to do blood culture, sputum culture, Legionella, and pneumococcal. And in case of severe obstructive lung disease, sputum culture should give us a clue for diagnosis. In the case of pleural effusion, we have to look for blood culture, sputum culture. Along with this, we have to do a thoracosynthesis and send for pleural fluid cultures also for analysis of the causative organisms. So, when a patient comes to our OPD, we have assessed for the epidemiological factor and we got to know whether he is having community acquired pneumonia or not. But to decide on when to take the patient, treat the patient as an OPD or to admit the patient or to admit the patient in ICU, there are some risk stratifying techniques available. The most important and the more commonly used is the CRP65 score. If the CRP65 score is more than 1, the patient should be considered for admission. This is the CORP65 score, and this we can commonly employ in our routine OPD practices. Like when a patient is in the confused state, we have to give 1 point for that. And the blood urine antigen is more than 90 milligram per deciliter, we can give 1. And respiratory rate is more than 30 breaths per minute, or systolic BP less than 90, or diastolic BP more than or equal to 60, we have to consider it as 0.1. And age more than 65, we have to give 1 point. When there is no blood investigation available, we usually take this confusion, respiratory rate, and BP and age. That is the CRP65 score. So if the score is 0 to 1, it is low risk, and we can consider outpatient treatment. And if the score is 2, we can ask the patient to get inpatient treatment. And if score is 3 or more than 3, the patient will be requiring hospitalization and intensive care treatment should be advised. So this is the CRP65 score. And pulse oximeter can be used to admit a hypoxemic patient. Hypoxemia is usually defined as pulse oximetric saturation less than 92% in age less than or equal to 50 and less than 90% in age more than 50. So patient can be triaged as a case of ward or ICU admission based on the ATS guidelines criteria. I will show the criteria in the next slide. So if any of the major criteria, more than 3 minor criteria is fulfilled, then patient should be admitted to the ICU. So this is the ATS guidelines criteria. When the major criteria is invasive mechanical ventilation or septic shock with need of vasopressor. And the minor criteria is like respiratory rate more than 30, PaO2, FaO2 is less than 250, multilobar infiltrates, confusion, leukopenia, thrombocytopenia, hypothermia, hypertension. Any 3 of these features is there, we have to consider admitting the patient in ICU. So this is the approach algorithm for a patient with community acquired pneumonia. When a patient is having clinical and radiological features of pneumonia, and if chest X-ray is available, which is showing the radiological features of pneumonia, then we have to treat the patient as case of pneumonia. If that is absent, we have to consider for alternative diagnosis. If the features of pneumonia is there, then we have to calculate for the CRP65 score. If the CRP65 score is less than 1, we have to check for oxygen saturation. If the oxygen saturation is less than 90, which is showing hypoxemia, then we have to admit to healthcare facility. If there is no hypoxemia, then we have to treat the patient as an OPD basis. So once the patient got admitted to a healthcare facility, we have to do the chest radiograph, followed by blood investigations like urea, electrolytes, blood counts, ABGs, cultures, and sputum stain, gram stain and culture. Followed by that, we have to administer the first dose of IV antibiotics on admission to the hospital. So whether to decide on ICU or non-ICU admission is by the ATS criteria, which we discussed in the previous slide. And if admitted to the ICU, we have to do LFT, creatinine, Legionella antigen assay. So these are the summary of scores available for stratifying the patient whether to admit in the ICU or ward. Like this CORP65 and CRP65 we have seen, and this is the ATS guidelines. This is another score available, the SMOC COP. But we routinely use the CRP65 score and this ATS IDS criteria for stratifying the patients. So next we'll go for the treatment part. What are the antibiotics which are useful for empirical treatment in various settings? So when a patient is diagnosed as a case of community acquired pneumonia, the antibiotic should be administered as early as possible and timely is more important in severe community acquired pneumonia. So in an outpatient setting, the therapy should be targeted towards the Streptococcus pneumonia, and the patient should be divided into the patient with comorbidities and without comorbidities. For a patient without comorbidities, the recommended antibiotics is oral macrolides like azithromycin or clarithromycin, or oral beta lactams like amoxicillin. Either one of the antibiotics should be started for a patient without any comorbidities. For a patient with comorbidities, combination of both beta-lactam plus macrolide can be given, and there is insufficient evidence for recommendation for tetracyclines. And chloroquine should not be used for empirical treatment in the case of community acquired pneumonia, as it is commonly used as a second-line drug for managing of pulmonary tuberculosis. And antibiotics should be given an appropriate dose to prevent emergence of drug resistance. So indication for a combination empirical therapy or chronic heart, liver, lung, and renal disease, diabetes mellitus, alcoholism, malignancies, and use of antimicrobials within previous 3 months, and severe community acquired pneumonia. These are the common doses of antibiotics which has to be started. And we commonly give ceftriaxone as 1 to 2 gram twice daily, or cefotaxime 1 gram, and piperacillin and tazobactam 4.5 gram 4 times a day. And these are the common antibiotics which we use. In an inpatient non-ICU setting, the recommended regimen is beta-lactam plus a macrolide. So we commonly prefer taxine, zone, and amoxicillin. When there is resistance or a hypersensitivity reaction to the beta-lactams, in that scenarios we can use fluoroquinolone after ruling out the diagnosis of tuberculosis. So on the route of administration, it is based upon the clinical condition of the patient and its treating physician judgment. It can be regarding to tolerance and efficacy of chosen antibiotics, whether we can give it as an oral or a parenteral antibiotics. In an inpatient setting, the recommended regimen is beta-lactam plus macrolide. When a patient is having a risk of pseudomonas, we have to consider starting the patient on piperacillin, tazobactam, ceftazidime, cefoperazone, sulbactam, ibipinum, or meropenem. And combination therapy can be considered with addition of fluoroquinolones when there is resistance to any of the above antibiotics. So antimicrobial therapy should be changed according to the specific pathogens isolated, and along with managing with antibiotics, diagnostic or therapeutic intervention like thoracentesis, chest tube drainage should be done. And if a patient does not respond to treatment within 48 to 78 hours, he should be evaluated for a cause of non-response like development of complications, presence of atypical pathogens, drug resistance, etc. So when a patient can be discharged, we can switch to oral from IV therapy after clinical improvement in a case of moderate to severe CFT. Patient should be considered for discharge if they are accepting orally afibrin and the hemodynamic is stable for a period of at least 48 hours. So outpatient should be treated for 5 days and inpatient should be treated for 7 days of IV antibiotics. So antibiotic can be continued beyond the period which we mentioned in a case of pneumococcal pneumonia, streptococcus, and legionella. And when it is associated with other infective comorbidities like meningitis, endocarditis, or any complication pneumonia or a lung abscess, in all those cases, we can extend the duration of antibiotics based on the patient response. And for discharge, this is the criteria for clinical stability which we follow. Like temperature should be less than 37 degrees Celsius, heart rate should be less than 100, respiratory rate should be less than 24, and systolic BP should be more than 90, and saturation should be more than 90%, and it has stability to maintain oral intake and normal mental status. When a patient is showing all these signs for the last 40 to 72 hours, then we can consider the patient for discharging. Role of biomarkers, it is not routinely used in managing community acquired pneumonia or to guide antibiotic treatment. And adjuvant therapies like steroids are not recommended for use in non-severe community acquired pneumonia. Steroids can be used in septic shock or ARDS based on the sepsis protocol. And there is no role of adjuvant therapies like anticoagulants, immunoglobulins, just probiotics, and over-the-counter cough medication. Chest physiotherapy should be usually avoided in the patient with active pneumonia, either if it's having a right lower lobe pneumonia or consolidation. There is a high chance that when we are giving a chest physiotherapy to those patients, that infection can spill over to the other lobes and segments. So in a case of lobar pneumonia, that we should try to avoid chest physiotherapy. Immunization, the routine use of pneumococcal vaccine among healthy is not indicated, but when a patient is having a comorbid conditions, then pneumococcal vaccine should be considered. Influenza vaccine should be considered in all the patients for the prevention of community acquired pneumonia. And the main thing is smoking cessation. Because smoking cessation should be advised to all the patients who are treating as a case of community acquired pneumonia, because that will impair the immune response. So these are the highest group where vaccination is recommended. The pneumococcal vaccine in case of chronic cardiovascular disease, diabetes, and alcoholism, asthenia. Influenza vaccine is recommended in chronic cardiovascular pulmonary disease, renal dysfunction, hemoglobinopathies, and immunocompromising conditions. And in all these group of patients, we have to recommend vaccinations. And a small touch on hospital-acquired pneumonia and ventilator-associated pneumonias. Hospital-acquired pneumonia is when the patient is an inflammatory condition of the lung parenchyma, where the infectious agent is neither present nor incubating at the time of hospital admission. It is defined as pneumonia developing after 48 hours of hospital admission. HAP can be further classified into ICU or non-ICU, depending on whether the infection is required in the intensive care setting. VAP is usually defined as pneumonia that develops after 48 hours of endotracheal intubation. And patient who develop pneumonia while being in NAV is considered as hospital-acquired pneumonia, not a ventilator-associated pneumonia. So, approximately half of the patient who's developing VAP will develop within first 4 days, and the intubation process itself contributes to the risk of infection. So, they are divided into two parts: early and late. Early onset hospital-acquired ventilated pneumonia usually have a better prognosis because those organisms will be antibiotic sensitive. But when a patient is having HAP or VAP after day 5 or they are more prone for MDR pathogens and are associated with higher morbidity and mortality. So this is the risk factor for multi-drug resistant pathogens like antimicrobial therapy preceding 90 days, current hospitalization for 5 days or more, or high frequency of antibiotic resistance in the community or the particular hospital unit. These are more common causes for developing MDR or HAP and any immunosuppressive disease or therapy. And now currently this healthcare associated pneumonia component is not there in the guidance. We are not following those things. The incidence of VAP is around 16 to 53.9%. And the common pathogen isolated in the ICU setting of we got Pseudomonas, Acinetobacter, and Enterobacter, followed by the MRSA. So this is a clinical condition associated with this hospital-acquired pneumonia. Hospitalization, the more common organisms will be Pseudomonas, Acinetobacter, and Enterobacter in most of the conditions. And in a patient with chronic dialysis and infusion therapy, we have to consider the MRSA pathogens. So when we should suspect HAP or VAP, when the patient is getting hospitalized, if we started developing new or progressive radiological deterioration, along with the new onset fever, secretion, purulent secretion, leukocytosis, and decline in oxygenation, we should suspect developing HAP or VAP. And this is a modified CDC criteria for diagnosing community HAP or VAP. Fever, leukopenia, altered mental state, new onset purulent sputum, or change in color of the sputum, or worsening of the gas exchange, like need for increased water requirement, or increased ventilator demand, or new onset or worsening cough, dyspnea, tachypnea, or presence of new chest signs like rales or bronchial sounds. So this is the algorithm I will tell in short form. So when a patient fulfills these criteria of HAP or VAP, then we have to consider sending the patient for sputum or blind tracheal aspirate and stop the patient on empirical antibiotics. We have to assess for clinical betterment after 72 hours. If patient is improving and culture positive, we have to de-escalate based on the culture. If patient is improving and culture negative, there is a scoring system which we follow for de-escalating the antibiotics or course of therapy. That is called a CPIS scoring. When a patient, after 72 hours, if the patient is not improving and if it is culture positive, you have to change the antibiotic based on that. And if culture is negative, you have to repeat microbiological workup and search for other source of sepsis and suspect non-infective cause of worsening of pneumonia. So this is the score which we used for assessing the escalation or de-escalation of antibiotics in a case of intensive care setting. This is the CPI score, like tracheal secretion, chest X-ray, temperature, leukocytes, and PaO ratio. These are the major factors, and microbiology will be giving additional advantage to all these scoring. If the score is less than 6, we consider it as good or poor. If it is more than 6, we will tell that the patient is deteriorating. So the antibiotic management in an ICU setting of initial therapy should always be started with anti-pseudomonal penicillins or third or fourth generation cephalosporins or anti-pseudomonal carbapenems like meropenem or imipenem. Along with this, we have to add an aminoglycoside or a fluoroquinolone. And if MRSA is suspected, then we have to add vancomycin or teicoplanin. General principle is we have to try to switch to monotherapy as soon as possible when the cultures have been ready. If culture is negative, we have to continue aminoglycoside and fluoroquinolone for the duration of 5 days. So these are the preventive strategies for VAP, like oral cavity decontamination with 2% fluoroxetine, hand hygiene, use of sedation and weaning protocol, use of NAV and try to avoid intubation, subglottic secretion drainage, and HME filters we have to change it regularly. And closed suction system should be used for suctioning the patient over an endotracheal tube. And proper and timely disposal of condensates and maintaining tracheal cough pressure less than 25. This will prevent mucosal injury in the trachea. And regular postural mobilization to prevent stasis of secretion and use of normal saline for suctioning and proper sterilization is required for the nebulization chambers. And the following strategy is not recommended in prevention of VAP. Antibiotics should not be used for preventing VAP, and selective digestive tract decontamination is not indicated. And routine ventilator circuit change is also not recommended. We have to change the HME filters alone to prevent this VAP to get. And to summarize, when a patient is having a history, physical exam, history for suggesting of common type of pneumonia, with the radiological features of infiltrates are present, then we have to determine the site of care, whether based on this scoring like PSI scoring, CURB scoring. Then when the score is low, we are CRB score is 0 to 1, we have to consider empirical therapy and outpatient management. But if the score is CRB score is more than 2, we have to consider hospitalizing the patient. And we have to consider other factors like prior condition, hypoxemia, and if you feel like patient needs to get admitted, like if they won't continue oral antibiotics properly and they require close monitoring to further progressing into a progressive disease, then we may consider admitting the patient in the hospital setting. Thank you.
Exhaustive brilliant small note here.
Yes, sir.
We generally talked about the saturation at 94 when COVID time. It's a cut-off number. The cardiac is less than 93 in literally. But last Western literature talks about 90.
90, yes, sir.
What do you practice yourself?
Sir, when I this 90 and 92 is the one we will usually mention it as hypoxemia, sir. But because when a patient of COPD, we will be recommending saturation of only if it is even if it is 88 to 90, we will tell that that's stable for his. Yes, sir. We will usually follow that.
But COPD in the cardiac is 94.
Request Dr. Ganapathy to come. Okay. Any doubts?